In this lecture, we will discuss sinus bradycardia and how it would appear on the EKG. Sinus bradycardia is similar to normal sinus rhythm. Both are sinus rhythms, but have different rates. The sinus beats in sinus bradycardia occur below the normal heart rate range. Otherwise, everything else should be the same as normal sinus rhythm. So let's go over what we see in sinus rhythm because it never hurts to do some review. So just as the name implies, sinus rhythm starts at the sinoatrial node or SA node. You may also hear it referred to as the sinus node. The sinus node is a small structure located in the lateral part of the sulcus terminalis at the junction of the superior vena cava and the right atrium. It represents the start of the normal electrical conduction system of the heart. So if you look here, again reviewing our conduction system, this is our sinus node. We have our internodal pathways that come to our AV node. Okay, this here is our Bachmann bundle on the left side. Then we have our His bundle that then splits off into our right bundle branch and then our left bundle branch that then subdivides into a left anterior fascicle and left posterior fascicle. Both of these then end in our ventricular Purkinje fibers that then innervate the myocardial cells. Okay, so as long as you can recall this normal conduction system in your mind, as well as where the leads are placed, and we'll look at that, identifying sinus rhythm on the EKG is really not that difficult. So let's go through our chart here. Okay, so sinus bradycardia, we said, originates from our sinoatrial SA node. Okay, and the only difference that we're noticing from normal sinus rhythm is an actual slow rate. The PR, QRS, and QT intervals are normal, but because you have this slow rate, sometimes they can appear slightly prolonged. Okay, so more on that upper range of normal, but again, they will still be within normal limits. Now, some causes that you could be aware of are some sleep. So just normally during sleep, we can have a slowing of the heart rate. All right, and sinus bradycardia is not uncommon during those times. It could be an increase in vagal tone, such as in athletes. Sometimes an inferior MI, if it affects the sinus node, can be a result and cause some of this sinus bradycardia. If the person is hypothermic, so the temperature falls, if they're hyperkalemic, high serum potassium levels, hypermagnesemia, high magnesium serum levels, hyperthyroidism can cause it, myocarditis, anorexia nervosa, intracranial events, surgical trauma. If you go in and intervene and affect that sinus node, you can maybe have some of this. Some channelopathies can cause it. Sinus node dysfunction, okay, so problems again at that sinus node, and then medications such as beta blockers, calcium channel blockers, digoxin, amiodarone, opioids, and barbiturates. All these can affect and result in sinus bradycardia. Now, in terms of the regularity, just like normal sinus rhythm, we have a normal regular rhythm, okay? And remember, when we talk about regularity, we can look at any interval. The one we should look at is probably the R to R interval if we can, okay? And what we'll see here is that these R to R intervals from one R wave to the next will be the same throughout, okay? All of these from one R wave to the next, these R to R intervals will be consistent and regular, and that's why we call this a regular rhythm. The rate, remember, this is the main difference between normal sinus rhythm. The rate is below 60 beats per minute in adults, okay? Remember, we said that it's age dependent in children. So again, you can go through here, and these are the values if you want to look through them and what would be below, okay? So again, newborn 90 to 155. If it's below 90 in a newborn, okay, you would consider that normal in adults, but if it's below 90 in newborns, we would consider that sinus bradycardia, okay? Now, in terms of the P wave, because we're dealing with sinus P waves, they'll be normal and present and constant, okay? So we'll have these P waves. This is a P wave here. You'll notice they're the same morphology throughout. And because they're coming from our sinus node, so our sinus node here, they'll be heading in this direction, okay, which is represented by our arrow here. So between 0 and positive 75 degrees is our normal P wave axis, heading leftward to the left side of the heart and then inferiorly, okay? So that's our in the frontal plane. In terms of the configuration, they'll be upright in those leads 1, 2, V4, V5, and V6, okay? So why is that? Remember, lead 1 sits here, lead 2 is here. Then in our frontal plane, okay, or horizontal plane, we have V4, V5, and V6 that represent our left lateral precordial leads, okay? So if you were to imagine them here, imagine lead 1 here, lead 2, V4, V5, in V6, okay, something like that, you can see why as the arrow heads in that direction, we will see upright P waves in those leads, okay? That's just what we see in sinus rhythm. So we said we can imagine this as lead 2. Now remember AVR sits here, which is in the opposite direction where that arrow is heading, so we'll see inverted or negative waves in lead AVR. In terms of V1 and V2, okay, so let's just erase some of this here. So in terms of V1 and V2, remember they are the right precordial leads. And what is our most anterior portion of the heart? Our right ventricle. Okay, so imagine them right here, right precordial leads right over our right ventricle. Okay, and what we're saying here, remember we're dealing with P waves, so we're looking above here at our atrial being depolarized. So the first vector, what happens in right atrial depolarization, it heads in this direction. Okay, it heads anteriorly, so towards V1 and V2, and that's why if you see a biphasic P wave in lead V1 or V2, going like this, the first part will be positive, representing right atrial depolarization. Then the second vector of the atrial depolarization heads posteriorly, okay, and depolarizes the left atrium. So because of that, it's heading posteriorly away from these leads. They will see a negative or inverted P wave, okay, and this represents left atrial depolarization. Now we can also see upright P waves in lead V1 or V2 or inverted P waves in V1 or V2. They're variable in leads 3 and AVL because of the respiratory cycles. Okay. Now in terms of the P wave to QRS ratio, we will see a 1-to-1 ratio. Okay, so for every P wave, we have a QRS complex. One P wave, one QRS complex. P wave to QRS. Remember, this is our T wave. P wave to QRS, okay? We'll have a constant normal PR interval, okay? So everything, our AV nodal conduction is normal. There's no block or delay. So remember, if we draw a complex here, this is our P wave, QRS, and our T wave. Remember that our PR intervals from the beginning of our P wave up until the beginning of our QRS complex. That's our PR interval. It should be between 3 and 5 small boxes in adults. Okay, so that's 120 to 200 milliseconds. The QRS interval will be normal. Remember the QRS interval from the beginning of our QRS complex to the end of it. That should be between 70 and 110 milliseconds, which is 2 to 3 of the small boxes. There should be no grouping and no beats should be dropped. Okay, so there's no problem with the beats. Every beat coming from our sinus node is making it through to the ventricles. Okay, so there's no issues going on there. All right, let's briefly review what we discussed before we end here, okay? So we talked about the sinus bradycardia, pretty much the same as our normal sinus rhythm. The only exception is our slow rate, okay? We talked about the rate here being less than 60. Let's just look at how we find the rate here, okay? Just so we can see the rate here. So this is one R wave to the next. We count the number of thick lines between 1, 2, 3, 4, 5, 6, okay? So it's between 5 and 6. So if you did 300 over 5, that would give you, what, 60 beats per minute? And then 300 over 6 is 50. So it's somewhere between here, okay? So if you did it about 300 over 5.5, okay, that gives you, what, 54.54, okay? So close enough, between about 55 beats per minute. And you would see that the same throughout, okay? So again, less than 60. So that's how we would find the rates. So slow rate is the main differentiating factor that I want you to be aware of. Everything else is pretty much the same. In terms of the intervals, when we talked about the PR, the QRS, and the QT interval, QT intervals from the beginning of our Q wave to the end of our T wave, these are normal, but they may be slightly prolonged in terms of being at the upper limit of normal. Okay, they're still going to be within our normal limits. Okay, so while PR interval may be 200 milliseconds, is still at the within that normal limits and not prolonged that we're thinking of a AV nodal conduction block or something. We talked about a bunch of causes. They're listed there if you want to go through them. Okay, remember, sleep is common. If these patients are asymptomatic, you really don't want to mess with it. Okay, this is a normal thing, especially when parasympathetic activities increases. Athletes, right, they'll have low heart rates, so if they're asymptomatic, leave them alone. Okay, now regularity, regular rhythm, okay? Our intervals are the same, they're constant throughout, so no problem there. We talked about the rate, should be less than 60 beats per minute, and then it varies based on the age, but again, we'll focus on our adults. The P waves will be the same as the normal sinus P waves, okay? So they'll be upright in those left lateral leads, 1, 2, 4, 5, and then V6, okay? You'll see inverted P waves in lead AVR, and then V1 and V2, they could be upright, inverted, or biphasic. Remember, if they're biphasic in V1 or V2, it's positive then negative, okay? And then variable in 3 and AVL. The P wave to QRS ratios 1 to 1. Our PR intervals normal, constant between the 3 to 5 small boxes. QRS interval again normal, 70 to 110 milliseconds. Okay, so that's something to be aware of. Remember, it could be at the upper range of maybe 110 milliseconds, but it never goes beyond and is abnormal. There's no grouping. Again, no beats are dropped. Well, that's the end of this lecture. We discussed sinus bradycardia and how it would normally appear on the EKG. I hope you learned something.